we're starting the epidemiology section of the course. Any questions or thoughts from, I don't care. Depends on who's going to stay awake or not, the lights off. That's what it ultimately comes down to. Yeah, post-lunch, lights are dim, epidemiology, yeah.
Short day that helps.
Short day, yeah, that's true. Once again, they said we're gonna, start the day off nice and end it with the real banger. So, okay. So, any questions, any insights from the journal club we did yesterday? Anyone find that somewhat useful, perhaps? Maybe.
Yeah, because our article was kind of confusing, so it's good to dissect it.
Yeah, and it was a little bit more sophisticated, I would say, than the first one that we did. It was pretty much a straight putt. But it's good to get, a variety of different things to talk about and to see how different ways that, you can kind of slice and dice the information. So hopefully that was somewhat useful to at least illustrate the concepts that we're going to be making here. Right, so we're kind of entering into section 2 of the course here with epidemiology. You guys can see that on Canvas, correct? Start with lecture 11 here. So let's talk some basic principles and concepts. As always, if you have any questions, please stop me and let me know so we can clarify any issues here. It's really important, though, that we started with the biostat, so at least we'll have a good background, a good fundamentals when we're actually getting into the epidemiology side of things. Even though it's kind of changing gears a little bit, you'll see there's still some concepts that are going to be important here. So what is epidemiology, really? Anyone know? It's like study of the populations. We're looking at, and specifically here we're more curious about like disease in the population, right? So we're seeing how diseases are happening. We're seeing how interventions that we're making are changing things. This is kind of what we're really getting into. And so this has a huge impact on things like public health, right? So we're not necessarily looking at how is using a beta blocker in this one particular patient going to affect their mortality, but more looking at overall sort of systemic issues in the population here, right? And so an epidemiologist would just be really anyone who is working with this data here. Frequently, at least the ones that I got to work with most frequently were in the health department. They have frequent epidemiologists that will work there, and they look for trends and things. So for instance, at the Poison Center, we definitely helped out with epidemiology, and that's why certainly whenever you guys are out there practicing, if you encounter something like a poisoning case, or a snake bite or an accidental ingestion, call it into the Poison Center because we track that sort of stuff and we look for trends and things like that. So for instance, if we are, say, heading into a hurricane and we get a bunch of calls about carbon monoxide, we can start to track that sort of thing. Now, why do you think hurricanes and carbon monoxide poisoning coincide? People are in generators, right? And so they don't want to run them out in their backyard or they might get stolen, so they put them in where? In the garage. And guess what happens to all that nice carbon monoxide? Same thing happens with what happens with the car if you were to run it in the garage, and so people get intoxicated from that, right? So those are the kind of things we look for. Or for instance, is anyone familiar with the term bath salts? That is certainly within your generational purview. You can probably remember the bath salts. What was notable about bath salts? Yeah, it caused someone to eat your face. Actually, I'll have you know that gentleman who ate the other gentleman's face, in fact, had none of the common bath salts found in his system. I don't know what was in his system, but it was not anything good, I can tell you that much. Regardless, though, that's part of the epidemiology, right? So we get these calls from places like ERs, and they say, I got this patient who came in, he's coming in, he's tachycardic, he's hypertensive, he's diaphoretic, he started seizing, and he had this packet of the stuff that said white rush. So it's bath salts, not for human consumption, right? One call in and of itself is not all that particularly interesting, but when you start to get several calls and they're coming in all from over the state, then you start to piece together a picture, right? We can look for these trends, we can look for these things, because they might be an early warning sign, right? So that's just one way in which epidemiology may end up affecting practice. And we can put out big notifications about that, right? We can say, hey, listen, look out for this stuff. Here, based off what we found, this is how these patients will present, right? So that way when you run into a patient like that, you know, okay, they might be a seizure risk. Let me go ahead and get medications available for that, or things like that. Anyway, what is health? What health is? Something you're losing every day potentially. No. Well, it's according to the World Health Organization, they have their own definition of it. And again, it's not just the absence of disease, but it's also looking at things like holistic, physical, mental, social well-being. And so a lot of things we look at in epidemiology will affect some factors of these, as we'll see. Preventative medicine, obviously, an ounce of prevention is worth pound of cured. You guys don't even know. Wow, you guys need to learn your I don't know, colloquialisms, perhaps. It's a good term for it. I really got canned there.
Can't believe that.
Yeah, it's a good word. Anywho, So preventative medicine, obviously, so if we can do things beforehand, we can look at the impact. So for instance, you may remember this example from the biostat section, but they talked about like testing every single married couple who's going to get married, like testing them for HIV. Remember that, like how much of a cost impact that made, and like how many people do they really find actually have HIV? Like almost no people, right? So again, it was such a high impact, such a high cost, it really didn't make sense to do that. This is part of what we can do with epidemiology, to look at like certain interventions and say, what can we do in terms of preventatives, and what kind of output are we going to get from that, right? So in Florida, I know we have a lot of programs focusing on smoking cessation, right? So again, how much money do you put into the smoking cessation program, and then what kind of outcomes could you look for to see if they're effective or not? Decreases in maybe in lung cancer rates. You could look at cigarette sales, maybe. You could look at lots of different things, right? So this is part of what epidemiology is also looking at, is like see how preventative medicine works to keep people from getting sick in the first place, right? And public health kind of goes along with that. So what's an epidemic? Here, epidemic, it sounds pretty dangerous, right? What is that? Really, we'll talk about the definition more specifically, but it really means anything that's happening outside of the normal rates that would normally occur, right? So again, we're going to get a lot of cases of flu that come up during November, December. Is that an epidemic of flu? Not usually, because it occurs along normal rates, right? You wouldn't consider that an epidemic, right? However, if we start to notice that the U.S. population starts to have a higher propensity of people being obese, might that be an epidemic? Hear about the obesity epidemic, certainly, right? How about what other kind of opioid? I already gave it away. The opioid epidemic. Sorry. It's late in the day. My mind's not. We were interviewing all this morning, so my mind's already kind of like exhausted from that. It's more mentally taxing than you might actually think, but that way we ensure only the best people get here, much like you all, right? They'll have very nice things to say about you, whoever was volunteering. They said, "Wow, your students they really like it here." And I said, because they don't have a test today. That's why. But anywho, like, so for instance, like the opioid epidemic, that's a huge problem here because it is something where we're seeing more opioid deaths. We're seeing more people who are addicted to opioids higher than what the historical average was, right? So we'll talk more about epidemics. And again, it doesn't just have to happen in one place. It can happen across multiple places. We're going to talk about how we actually surveil for those sort of things in a later section here coming up. And so when we're looking at these changes that occur, infectious agents are usually a common one we're going to be looking at. So you're looking at spread of malaria or SARS or whatever the case may be. We can look for different things that may trigger these epidemics, right? So it could be due to increased virulence of the pathogen. Maybe it's introduced to a novel setting. So for instance, malaria cases over in Africa, are they pretty common? Fairly common. Over here, is it so common? Not so much, but if you have someone who can bring it over potentially in a novel setting, maybe it can start to spread a little bit more. How about like Zika virus? Remember when that was a big thing a couple years ago? Right, it was something that was being introduced into our environment that was not really used to it, and those mosquitoes started spreading like crazy. And that's why there's a big concern, especially who is really concerned about getting Zika virus? Pregnant patients, right? Because there's all kinds of teratogenic effects that would happen to that fetus, right? So, and that was a concern that really touched me because that was right about the time where we were between my first and second child, right? Fortunately, Phoebe turned out totally fine, right? She's great, but that was a concern we had at the time. I was like, wow, do we have to wait on getting pregnant until the Zika virus thing goes away? Like, who knows? But this is part of how public health can be affected by these issues here, right? Anyway, looking at changes in host susceptibility to the infectious agents, perhaps maybe we stop vaccinating people against measles, and guess what happens? People get the measles, right? So again, that's where we see these outbreaks that are occurring because of changes in things like host susceptibility. Could also be just due to exposures, right? So for instance, healthcare providers, are we at higher or lower risk for infectious diseases? We're at higher risk because we're just being exposed to it, TB, meningitis, things like that. And so again, it doesn't have to be a contagious issue. It could be something like West Nile virus, obesity. An epidemic really just means anything happening outside of the normal rates as per what the historical standards would be, right? So let's look at an example here. So cholera, it's an infection of the small intestine caused by this Vibrio cholera. And this is actually one of the first diseases that we were actually started tracking with sort of this new idea of epidemiology and actually looking to see like, okay, well, these people are developing cholera, but like, why is that? Like, is there perhaps a common source? that this is coming from? Is this perhaps due to some particular reason why this is popping up now all of a sudden? And so what we know about it now is that it's certainly a very severe in terms of its symptoms, causing very profuse watery diarrhea, vomiting. Patients would die basically due to dehydration and malnutrition eventually. And so what they also found, though, was the transmission occurred primarily via drinking water, right? Sometimes it could be contaminated food here, and then it would be contaminated by the feces of an infected person, and that could spread to someone else. If that got into, say, for instance, the water supply, you could see how that would spread amongst these individuals there, right? And so they found that worldwide it happens about 3 to 5 million people, and at least in 2010, you found, say, 100,000 to 130,000 people that actually died from cholera, and it was mostly in developing countries. And why do you think that is? Sanitation systems might not be as good, right? So they may not have a way to get clear water, and so in those cases, that's where cholera can then potentially be spreading there. So, but again, this is one of the first diseases we really started looking for, and this is back in late 1800s, right? So you guys are familiar with John Snow?
Oh, yeah.
Yeah. Well, he knew nothing at first because cholera was sort of an unknown sort of entity at that time there, right? But he was a physician back in England before he was taking the watch, right? And he really was the first one to identify this. Glad at least got one person. Anyway, but they actually brought it back. He was actually able to track to see where these people are popping up in terms of developing cholera, and actually linked it back to a common source. And actually, it was this one particular pump, this water pump, that was in England. Now, if you could look here, kind of what do you notice about the cases? The red dots here are the cases of cholera that are popping up. Do you kind of notice a geographical distribution? Yeah, so he was able to link it back, and you see, well, what is the common source that these people are actually going back to? And this white, or this yellow, I don't know my colors anymore. This blue circle here, it's like I'm trying to train my 3-year-old on her colors and shapes and whatnot. But this blue circle here was the common source there, right? And so what did they do? Well, they capped off that pump, and guess what happened in the cases of cholera? It dropped off pretty precipitously, right? So some of these things seem like common sense to us nowadays, but back in the day, they had to figure this out on their own. And so this is where these initial sort of epidemiologic principles started coming up, right? How about this case here called childbed fever, or otherwise known as puerperal fever or childbed fever? It was a bacterial infection that these women developed either during childbirth or after miscarriage, for instance. And this was back in the mid to late 1800s, where they were starting to look at this, and they found that the majority of cases were actually being caused by the physicians themselves. So the physicians were actually being the vector here and causing these women to develop bacterial infections. And so it's really kind of interesting the way they found this out. But this is before they even knew what germs were at the time, right? And so they didn't also think that hand washing was all that too important. Do we now know that hand washing is quite important? Yes, in most hospitals you work at, they will ding you if you don't wash your hands in and out of the patient's room. And in fact, they have little sensors that will track you, and if you don't do it, you get dinged, and you get a little public embarrassment. They say you're not washing your hands like you should, right? Probably not like public, but they still will ding you for that sort of thing there. And so there was this guy back in 1844, Semmelweis, and basically he was like an assistant lecturer. There's like a teaching hospital that they were working at, this obstetric division in Vienna. And basically medical students at the time were receiving their training. And so this sounds just totally wild when you actually hear the story here, but he was noticing that they had a 16% mortality rate with these students here, and it was higher than the 2% mortality rate where they were having the midwives actually practicing. And so you're like, okay, why is the physician's mortality rate so much higher than the midwives? Okay. And so, again, they noticed it also that it was rare in women who were giving birth before they actually got to the hospital. So what was the kind of the common link here? Well, what actually happened was we discovered is that the doctors were actually performing autopsies prior to going and giving birth. And so any of the bacteria that were growing on these corpses were then being introduced into these pregnant women. Seems like it's a no duh at this point, right? But they did not know anything about germs at the time. And so, but the midwives didn't have anything to do with the cadaver labs, and so they would just go, and they were relatively clean in comparison to the doctors, right? And so also they kind of noticed this because there was this one doctor who actually died of septicemia after accidentally cutting himself while performing an autopsy. So he's like, wait a second, this seems kind of odd that this, these women are presenting kind of the same thing as this guy who cut himself during autopsy. Perhaps there's a link here, right? So you find something you think may be a link, and you go and investigate it to see what happens. So then what he did was decided to start experimenting with different cleansing agents, and so what they noticed was that once they ordered all the doctors and students working in that first division to wash their hands, they would do that basically before starting any kind of work and then before each vaginal examination. And then guess what happened to their mortality rates? they dropped pretty precipitously, right? They went from, say, 18% down to less than 3% of the same year. So again, being able to see a direct cause and effect sort of thing there, and again, seeing decreased mortality. Now, you would think that, well, everyone would just catch on board to this and they'd say, well, this is obviously what we need to start doing, right? It actually took some time after that. Those people were just like, I don't know about this hand washing thing. It doesn't sound right. So anyway, you can see here that obviously history will kind of bear some of these things out, and we'll see that, well, yeah, they probably should have been doing that from the beginning. But if you don't know, you don't know, right? So what is epidemiology? Again, we're looking at these, studying the things that afflict or affect a population, right? So it could be smoking, could be obesity, could be opioids, could be lots of different things here. And we're looking for the factors that are going to determine that occurrence and the distribution of the disease in a population, right? So for instance, if you look at, say, the distribution of different types of illegal substances, and I'll probably bring that up a lot because that's just what I'm interested in, not recreationally, but just from a professional standpoint. But as an example, right, so if you look at, say, the type of populations that abuse, for instance, crack cocaine, like where do you normally find that? Well, it's usually inner city, usually poor populations, usually black. And then if you were to, say, look at something like methamphetamine use, where do you see that? Rural populations, again, poor, but also a little bit more on the white side of things, right? So again, you can find these distributions, and that's something that we're looking at. And then based off these distributions, based off these patterns, sometimes we can make these interventions, look for ways to actually affect that. And again, this is why we do a lot of the tracking. This is where these databases are so important. Again, that's why I find it really interesting, especially like a place like the Poison Center. All that information gets shuttled over to the health department, so that way they can look for these trends. They have the epidemiologists look to see, hey, is there any interventions we need to make here? And then they can act on that almost in real time. Actually, it's pretty fascinating how quick that we can jump on some of these cases as soon as they start popping up. But anyway, we can do it at several different levels here, all the way from the submolecular all the way up to the levels of populations, right? Now you are going to be working on sort of on what level? On the individual patients, right? So this is why it's really important when you run into stuff that you report it as appropriate, right? Certain things are mandatory reporting. Anyone know what some examples of those are? Yeah, like STDs are a big one. They have to be mandatory reported, like meningitis has to be mandatory reporting. So there's a whole list of them. Certainly oddball things that are like, if you have a patient who developed Ebola, do you think you'd be likely to report that? Probably, but again, if you work in an STD clinic, you have someone that tests positive for gonorrhea, do you really care about that so much? Maybe not, because you see it every day, but that still means it needs to be tracked, right? So we'll talk about underreporting and things like that, but you will directly feed into the study of the populations, right? The epidemiologist will be able to take that individual data as it's reported and be able to make some actions on that, or maybe do some further investigations. So classical epidemiology, as we mentioned, is more population-oriented, is studying those communities, looking at their health problems, especially of infectious agents. That's kind of the most common thing they'll be looking at the time. But they would look at things like nutrition, the environment, the human behavior, everything that kind of fed into that. We'll look at some of the different factors that go into that in just a few minutes with some good examples. Clinical epidemiology is what we're going to be more focusing on, and this is going to use more research designs and statistical tools. So you guys pretty glad you took that biostat section already, right?
Yes.
Because you already know a bunch of statistical tools we're going to be using. We're talking about study designs and all kinds of things. But that's going to help us to look deeper, right? We're going to be looking at how we actually care for patients and look to see, like, well, based off this study of the population, how should I be treating my individual patient, right? Taking that broad information and try to think it back, see what's generalizable to the patient you got right in front of you, right? And again, we'll talk about things like clinical treatments, comorbidities, and all how that can affect everything. So looking at the stages of the disease when we're kind of evaluating different aspects of epidemiology, we have the pre-disease stage, right? So this is where before the pathologic process actually begins. This is where we may focus on a lot of early interventions, right? They may prevent exposures entirely. So for instance, by looking at things like potential lead exposures, right? By trying to eliminate lead exposures to individuals, you can prevent lead toxicity, hopefully, right? Things like that can be very useful. Or if we perhaps maybe vaccinate individuals to prevent the disease from ever actually occurring in the first place. You tend to find you get the most bang for your buck out of these sort of interventions, where if you can prevent the disease from ever occurring, then you ultimately end up saving a lot of money, a lot of heartache, a lot of quality of life, etc. Once they actually get infected or they've been exposed to it, this is what we call the latent stage here, where, again, it's still asymptomatic, right? And why might this be problematic for other individuals? Could be contagious, right? Depending on what we're talking about, you may still find that it could lead to treatment or other people becoming infected. We also know this is tough because it can be difficult to find the right patients to treat to determine who needs to be treated. But this is where things like screening and appropriate treatments can be developed early on, right? So for instance, when we were worried about Ebola, for instance, a couple of years ago, we were worried about Ebola coming in, we would do screenings for every patient that came into the ER. We would ask them questions about, anyone know what we'd ask them? Travel, and it would actually be very specific countries. So like Sierra Leone was on there. I'm trying to remember any other ones. Maybe the Republic of Congo. I think there's a couple of places like that. But basically, it's very specific though. So again, if you had that history, that was that screening tool. The patient may be asymptomatic, but they still could have had an exposure, right? That was an early time to intervene before they actually became symptomatic. That's called that latent stage. And in the symptomatic stage, where the disease manifestation is already evident, and again, this is going to be kind of late in the game here, but this is where we can hopefully either slow down, arrest, or maybe even reverse progression of disease. But again, the earlier you can get into it, the more preventative you can be, obviously the better it's going to be overall. And so when we're looking into the mechanism or the causes for disease, again, oftentimes we're going to look for both the biological mechanism, but there also could be social and or environmental mechanisms that could be playing a role here, right? So for instance, osteomalacia. We're looking at different social and biological causes here. So for instance, women who practice Purdah of the Muslim faith, they frequently do not have a whole lot of skin being exposed to the sun. And so what do you think that does to vitamin D production? It should decrease it, right? So what they would actually find is that due to a lack of vitamin D or vitamin D deficiencies being induced by this practice, it actually led to, and actually had some poor dietary intake, led to things like osteomalacia. They also see fetal mortality due to distortions of the pelvis. So again, even though it was a sort of a social, religious thing that they were practicing in, you can see how it led down to physiologic changes, right? So these are things that we would be able to pick up on by looking at epidemiologic investigations, right? So you guys are familiar with like the host, agent, and environment sort of triad? They have influence on one another. You at least look like the malaria cycle before. We'll kind of look at that again here, but it's a triad of factors that will affect disease. We'll see the fourth factor here is going to be the vector, as we'll mention in a moment. But looking at malaria, obviously the host here is going to be you, the human, right? The agent is going to be this plasmodium. And we'll see that in the environment, typically it's going to be more in places like tropical climates, stagnant water, and then the vector happens to be Anopheles mosquito, right? So again, we can see how there's an interplay between these different factors here that are going to go into people ultimately developing malaria. But you could look at this for anything, really. You could look at, for instance, patients who are at risk for opioid use. You could look at this for patients who are at risk for obesity. I mean, there's a lot of different features here that you could apply this to. But again, there's this interrelationship between all of these, between the vector, the agent, the host, and the environment, right? So again, these Anopheles mosquitoes are going to be more likely to be hanging out in more of these tropical environments. They're going to be more likely exposed to the agent, that plasmodium, and thus the more people that are there, the more hosts they can then interact with. So you might imagine how this occurs here. And so again, the host factors are oftentimes the things that we can change potentially in order to help prevent disease from occurring, right? So for instance, you may find that a host resistance can be influenced by things like their genotype. So there are certainly genetic factors that could play a role here. So things like skin color. If you have darker skin, typically you're less likely to get sunburns, right? That could have an effect on cancer rates, right? Presumably, because you don't have that DNA damage actually happening to those skin cells. For instance, with BMI, we know that as obesity becomes more prevalent, what sort of diseases are they more likely to develop? Diabetes, cardiovascular disease, stroke, all kinds of things, right? So looking at the immune system, right? Looking at this to see the resistance to, say, cancer or microbial disease. Obviously, you're looking at patients who are immunocompromised, they're more risk for different infectious diseases, things like that. And then obviously social behavior. So for instance, if you're exercising, we know that definitely enhances resistance or increases the resistance to a lot of different diseases, like the ones we mentioned with diabetes, or I'm sorry, with the BMI. But for an example here, see measles is something that's seldom fatal in well-nourished individuals. And this is even before the time we actually had immunizations against measles. But in those patients who are starving or protein malnourished had about 25% mortality. So you can see here that it's the same infectious disease, but depending on the host factors, namely if they were well-nourished or not, you can see it had a very significant impact on mortality. And so again, oftentimes we're looking at all these different factors, these different things we may consider confounders, and how they may influence that patient's going to develop severe disease or not. So looking at agents of disease, there's a lot of different things that fall into this. So things like biological agents, so it could be allergens, infectious disease, biologic toxins. Anyone think of any biologic toxins playing a role here? This could be something like anthrax. It could be like Botox, like botulism. Could be something that could be a biological warfare agent, right? Food certainly, right? So another thing that we track a lot at the Poison Center is when people call up and they are having severe gastrointestinal symptoms and say, oh yeah, I was eating at this, I don't know, discount sushi place out of the back of a gas station, and all of a sudden I'm having horrible diarrhea and vomiting, and then we get like 5 more calls that are like that. Oh yeah, I was eating at that same place. Right, we can link those sort of things. We can look for disease clusters, and as they gets reported over to the health department, then guess what they can do? They can go in there, shut that place down. So listen, 99-cent California rolls, while it may sound appetizing, can be quite deadly as it turns out. So don't do that, right? Get the good stuff. Anywho, but yeah, so we can look at things like circumstances, the environment that is going to play a role here in terms of like poor restaurant sanitation, poor weather, road conditions, anything like that. I will tell you that one time my favorite restaurant ever in the entire world got closed down. I certainly have this bad predilection towards really bad Chinese buffet restaurants. And so there's one in Jacksonville, and ironically it was right next to a Firehouse Subs, so that'll be ironic in a second. But they always had really poor sanitation ratings, and actually the health department came and shut them down one day. And so I was very distraught, and I said, well, they're going to open them back up, right? They said, no, they're not going to open it up. I said, why not? Because they burned the place down. I go, what? So yeah, they burned the whole place down and took the firehouse down with them. I said, oh no. They were trying to get the insurance money, but it turns out arson investigations put a hamper on that. So needless to say, the restaurant did not open back up, so we had to find somewhere else to eat. Anywho, though, you can see how different factors here can play a role on disease, and so there are probably some people getting diseases from that restaurant. So anywho, looking at the vectors, a lot of different factors here can be vectors, including insects, arthropods, animals for sure. How about like the vector for rabies, right? What are some common animals here that can cause rabies? Raccoons are a big one. Squirrels are not really high on the list. The other big one are bats, right? You got to think about bats. If you ever like have a patient and they have the history like they woke up in the middle of the night and they saw a bat in their room, you may think like, who would ever have a bat in their room? But this is Florida, right? People do Florida things around here. So even if they see a bat and they have no visible bite marks, they still have to be ruled out for rabies, right? Because the risk is so high because so many of those bats actually end up carrying that. But yeah, so again, there's very specific circumstances. We'll get into those later on. But also you could even consider like groups of people to be vectors for disease. So for instance, drug dealers, right? So if they are spreading around, say for instance, we are now seeing a rise in deaths due to fentanyl, okay? Now fentanyl, anyone know where you normally see fentanyl being used?
Nursing facilities.
Maybe nursing facilities, but usually like in surgery, right? Usually in the hospital sort of setting here, but we're finding all these patients with opioid abuse disorders are dying out in the outpatient world from fentanyl. Anyone know why? A lot of the heroin is being laced with fentanyl now. So even these people are going and buying heroin, they think that, okay, this is my normal dose of heroin, not realizing it's been spiked with fentanyl, right? So again, the agent in that case would be the fentanyl that actually caused a patient to overdose and stop breathing. Here, the vector could specifically be the drug dealer, right? So maybe they were trying to make an extra couple bucks because fentanyl is so potent that you could use very small amounts and spread that over a lot of doses. But again, I wouldn't trust myself with any kind of science experiments like cutting drugs. I wouldn't trust these guys who have no education. And so that's where they run into these problems. They get a lot of fentanyl in one dose, kill somebody. In that case here, they are actually the vector for disease. And again, there has to be this relationship between the agent, the environment, and the host for that to be an effective transmitter of disease. That's kind of the thing we're going to be looking at. Again, malaria is kind of this really good example. Obviously, the mosquito is going to be carrying the plasmodium, has to be able to transmit that into the host, and then we see it will then have its incubation period and then replicate, and then other mosquitoes can actually pick it back up and then spread it to others, right? So again, this is how the vector, being the mosquito, is going to be able to affect the rest of the 3 factors there. Okay, so getting into those specific factors, let's talk about the Beings model. And so these are going to be major categories or risk factors for disease. Okay, so at least for testing purposes, if I were to give you an example of one of these, you should be able to pick it out to say, like, is it more of a biologic factor or behavioral factor? Is it an environmental, etc.? These will be pretty evident, right? So if I was saying a patient has this genetic disorder that predisposes them to X, you'd probably say it's what? A genetic factor, right? So some of this seems like it's kind of common sense, but it's good to be able to identify these because again, it could be multifactorial depending on the problem that we're looking at. But I'll give you some examples as we go through these. Now, again, risk for disease, as we're going to find, can be influenced by gender, age, weight, all these different things here. And so in terms of these behavioral factors, we'll see that smoking is a really good example of this, right? So what does smoking put you at risk for?
Everything.
Like everything, right? I think the only thing that the cigarettes are actually protective for, anyone know?
Wait.
I guess weight, yeah, that's true. You certainly may lose some weight when smoking. There's actually like Parkinson's. I think there's some protective factor for Parkinson's, but I'm like, I don't know if that's really worth the risk for all the other stuff you're going to get from that. But interestingly enough, not just smoking traditional cigarettes, but what's some kind of the recent trend that we're seeing more issues with? A lot of the vaping, like a lot of Juuls and things like that. You know, these different products that patients are using. Is any of that stuff regulated? No, right? You can buy anything online, you can get from different countries, there's no strict regulation on this kind of thing. And so that means that whatever solutions they're getting to put into these devices, we have no idea what the heck's in it, right? A lot of times there's things like, different alcohols, ethylene glycol and propylene glycol, but there could be other stuff in there too, right? And so in fact, I've gotten several calls from the poison center now where these docs are calling up from the ER and it says this patient looks like their lungs are entirely whited out, but there's no fever, there's no white count to go along with it. They just have this history using this Juul. Like, what do I do with these patients, right? And again, I'm like, we don't know, because we don't even know what's really causing the problems here, right? So again, we tell them to treat them supportively and, obviously admit for observations and things like that. But they have these chest X-ray findings that are just so odd because they have these new chemicals they're inducing or bringing into their system here. So again, that's another thing that epidemiologists will be looking at for sure because it certainly is a hot topic issue. Anyway, but certainly, as we mentioned, smoking is a behavioral factor, right? Because why do people start smoking? Because of their behaviors, right? So it could be their environment has led them to that. They see their parents do it. Certainly in terms of like the e-cigarettes and Juuls and things like that, like if you're in high school now, that's kind of the norm. Like, I was doing a high school presentation with some pharmacy students probably within the past year or so, and we went to a high school and we were talking about the dangers of illicit drugs and all these kind of things. It's kind of one of the standard sorts of talks which are definitely super effective and prevent all high schoolers from ever abusing drugs. But anyway, I wanted to open it up to them. I was like, what kind of questions do you have? And so one of them brought up this case, and they were like, yeah, one time we had this like substitute teacher, and one person started like using their Juul, and then like everyone started using it in the room, and then the substitute teacher didn't really care, but then this girl started coughing a lot, and she had to go to the nurse. Is that normal? I'm like, high school is way different now than it was for me. I was like, yeah, I guess you could see that. Like, if you have that certain irritation, and again, if the whole room is just nothing but a smoke screen, like, my gosh. But again, these are the questions you might have to answer one day too when you're dealing with high schoolers coming into your urgent care or something like that. But anyway, but again, a lot of it's behavioral sort of issues here, right? And again, we know they contribute to a lot of different diseases. How about obesity, right? Causes several disease states, and again, this is more of a behavioral factor for many patients, right? So again, what kind of environments are they in? I mean, how, is it cheaper to go out and get food from McDonald's or to cook a nice fresh meal for yourself? Yeah, that dollar menu is something else, right? Like, you just go get all kinds of good food on. Yeah, so that's the thing, where people are like, oh, it's less effort for me to go get McDonald's, and it's delicious, and it's been chemically engineered to tickle that dopamine receptors and sort of stimulate that mesocortical pathway. Yeah, of course that stuff is going to be a behavioral factor they get kind of into. But again, these are things that we could do. We have inputs on, right? We can do things like have the restaurants put up all their nutrition information. Maybe that'll skew some people away from getting like a 1,200 calorie burger, right? These are things that may be able to have some impact there. Looking at some other things here, so other behavioral factors that can help with the spread of disease. How about things like HIV and AIDS? Obviously, we know things like IV drug abuse has led to spread of that. Unprotected sex potentially has led to some spread of that. Things like excessive intake of alcohol. Not that any of you would ever know anything about that, but what are some things that could lead to? Certainly things like cirrhosis, pancreatitis. What about acutely? What could it lead to? Trauma, right? We have a lot of patients coming to the trauma unit. Why? Because they're drunk, they got behind the wheel of a car. So I drive better when I'm drinking. Is that true? No, it's not true. And they get into a car wreck and then potentially kill somebody or themselves. So again, it doesn't have to be specifically these kind of disease states. It could be actual physical trauma they get into. Obviously, drug abuse has been associated with overdoses, driving while intoxicated. Again, trauma is kind of the big factor there. Homicides, suicides, right? So any of these things potentially could be behavioral factors leading to premature death for these patients here. And in fact, drug overdose is quickly becoming a very common way for accidental deaths and starting to overtake things like car wrecks and things like that. So this is a big, huge issue. We're especially, or at least I'm especially curious about, mainly because of the toxicology thing. So again, all these cases, changes in behavior would obviously prevent the untoward outcome. So if you decide to, if you have like a lot of interventions saying, hey, designated driver programs or something like that, right? Or maybe like the increase in the rideshare economy of Uber and Lyft, like has that had an effect on the number of DWIs that have been found? I don't know, but right, that would be something you could potentially investigate to see, hey, is the culture changing? Is it changing behaviors potentially, right? It's a lot easier to get an Uber nowadays than to get behind the wheel of your car potentially, right? Be something that could influence this sort of things, right? And again, these are a really easy way that we can have interventions from like a health, preventative health sort of standpoint to try to intervene early before the disease has actually occurred. How about environmental factors? Certainly, we can look at a lot of different issues here in terms of, say, for instance, like infectious disease in the environments that people are in. So if you hear about somebody who's working with an air conditioning unit and then they develop a pneumonia, Legionnaire's disease, right? But again, where does that come from? Legionella, where does that come from? Well, again, remember the American Legion Conference in Philadelphia, right? They're able to link this disease cluster that was happening as one particular conference, link it back to the actual AC unit, right? But again, someone had to make that connection to be like, wait a second, all these older gentlemen are showing up. I don't know if ladies were in the American Legion back then. I have no idea. But these older people were showing up and they were developing all this pneumonias. Like, what was the common link between all of them? Oh, wait, they all have the American Legion pens on, or whatever the identifiable features were between them. And they went back to that conference and found, okay, yeah, it's actually the AC unit that was harboring this Legionella. Or how about if you have a patient who, say, you know, they're out in North Carolina in the Appalachians and they're hanging around and all of a sudden they find a tick on them? Mountain spotted fever potentially, you know, different things like that. So there's different factors here. Lyme disease, you know, so these are environmental factors. Where was the patient at? What was the environment that they were in, and what led them to developing these diseases, right? Do you think you see a lot of shark bites in Arkansas? No, it's just not the right environment for it. However, if you're in Florida, you may be more likely to see that, right? Sounds silly, but that's the things we look for. Immunologic factors. This is a really important one, especially with changes in vaccination status and anti-vax movements and things like that. But smallpox is actually one of the first infectious diseases we ever thought was completely eradicated from the globe there. And it was mainly due to the early vaccination that we were introducing to these patients here. But certainly, herd immunity is a big deal, right? What is herd immunity? Yeah, the majority are protected against the disease. The few that are not protected still stay protected, essentially, right? But again, as the number of people who are protected tends to dwindle, what happens to those unprotected individuals? As the herd thins out, they're more likely to end up getting the disease, right? So again, that's something we're actually starting to see now, especially like measles outbreaks and whatnot. But again, a lot of it can do with immunodeficiency. Could be due to specific diseases that suppress the immune system, genetics. Chemotherapy is a big one, right? So we know that patients who are receiving chemotherapy are immunocompromised. Thus, we know they're at risk for fungal infection, viral infections, etc. These are all things that can directly affect that immune system. Getting into nutritional factors, right? So looking at things like, you know, well, why are certain disease states more present, say, in places like the U.S. than it would be, say, in other countries, right? And a lot of it can go actually back to our nutrition. And so here in the U.S., do you think we get enough fiber in our diet? Some people do. Some people. A lot of people actually do not. And so this is actually kind of an interesting study. There's this researcher. He actually was looking at these cross-cultural studies, and he came up with the following statements. He goes, by world standards, the entire U.S. is constipated. And working in a peds ER, the number of kids who come in complaining of abdominal pain, and they get an abdominal x-ray, guess what you find? They're FOS, full of stool. There's a lot of enemas we go through at the hospital, the peds hospital, because so many kids are either getting diets that are leading them to this constipation, they're dehydrated. These are big issues we run into. And again, those are many, many, many ER visits. I can't tell you how many kids we're actually admitting to the hospital just for a GI clean out. We have to give them, you guys ever heard of Go Lightly? Heard of Miralax?
Yeah.
So it's like a big 4-liter jug of Miralax that the patient's supposed to drink, and it's this osmotic laxative. They'll basically just force all the stool out, right? And again, when they say go lightly, there's nothing light about how these patients go, but they're being admitted for this, right? That's because they are so constipated that normal measures are not going to be working here. So again, this is the problem. This is what this guy's starting to notice here, right? He says like they don't diagnose appendicitis in Africa unless the patient speaks English, right? Kind of going back to the nutritional factors and how that is different between the countries here. Patients with large stools have small hospitals, and those with small stools have large hospitals, that I found interesting as well. So again, going back to the factor of how much fiber we actually get into our diet can have an effect on a lot of these different GI diseases we can end up seeing here. Now, you guys are definitely too young for this, but there's an SNL commercial back in the day about colon blow, which I always thought was very funny as a young child. Well, basically, the point is that when looking at these differences here, a lot of it had to go back to nutritional factors and how much insoluble fiber we're actually getting into our diet here. I like the wood shavings you can see on top of the cereal here. Very good fiber, as it turns out. Some genetic factors. Certainly genetics are going to be playing a role here, so we can certainly see in certain populations that genetics will play a role in terms of what diseases they may be more resistant to or more susceptible to, depending on the case there. Again, when you're looking at these populations, you can look to see, like, are they in equilibrium? Are things shifting depending on mutation rates and things like that? These are all things they're going to be looking at in terms of the genetics. Yes, sir?
What's your description of the difference between genetic and biologic factors?
So in terms of genetics, that's specifically looking at any type of like maybe polymorphisms or things that are like inherited along with the individuals, right? Biologic could be more like, I'm trying to think of a good example.
Use like risk factors like height, weight, and
yeah. So for instance, when we're looking at the biological aspects of it, it is more so. It's tough because sometimes it can get a little bit kind of skewed a little bit. Because for instance, here this is more looking at the behavioral. Let me see the biological. Yeah, it's more focusing on the behavioral factors here. Yeah, sometimes it could have a cross-linking there, but normally when they're looking at genetics, they're looking at sort of the trends of genetics in terms of like the populations they're following. So if you have something like an Anglo-Saxon background or if you have an African background, like how do those trends in the genetics actually have an factor there? It probably has some degree of an effect on the biologics, but usually when you're looking at the biologic factors, more like in the individual populations, like in the state of Florida or in the US or something like that. So usually the genetics are getting a little bit more granular from that standpoint.
Thank you.
Probably insufficient answer, but that's the best one I'm going to come up with right at the moment. But anywho, yeah, so we can look at things like looking at gene mutation rates, et cetera. Those tend to not change in the great scheme of things over the short term, and so we can look to see how stable they are over time. But certainly we do things like genetic screening for infants, for sure, right? So for instance, we can screen for things like fetal ketonuria, congenital hypothyroidism for patients as they're born. For instance, we did genetic testing we actually did the for my first and second child, we ended up doing the in vitro testing to see did our baby potentially have any of these conditions early, and we also did it so we could see what the sex of the baby was really early on. And so it's interesting because they're able to actually take blood from my wife and actually spin down and just get the fetal cells out of her, and actually we're able to genotype that and see what they potentially could have, right? And again, it was good, an early warning sign if anything was to come up. Fortunately, nothing did. Both of my kids are both very healthy, as long as Phoebe does not fall off the table because she figured out chairs and how to climb up. Anyway, but we could also, it's actually kind of interesting if you get those reports back, because when they're looking for the sex of the baby, they'll say whether the presence of the Y chromosome was found or not. And so when the report comes back, it says Y chromosome not found. And I was like, oh, well, it still could be a boy, right? And she's like, it's not going to be a boy. And I was like, but it could be. It's small. It was hiding out there somewhere. And she said, no, it wasn't. I was like, okay. So, they're both girls. I love them. They're great. Anyway, no, that's not going to happen. Lord willing, not going to happen. No. Anywho, so again, this is why it's good to get sometimes these early genetic features here, because we can actually look for, do genetic counseling beforehand. You can kind of plan these things out before, so that way you at least have a good idea what you're going to be encountering, say, when that baby's born, potentially. Or for instance, me and my wife both had genetic testing done, and one of us actually carries a copy of the gene for SMA, which is a childhood disease called spinal muscular atrophy, and it's a recessive condition, so both of us would have to have it. But because one of us has it, we would also want to tell our kids, hey, you might also want to get checked for it one day when you want to have kids, to see if your partner has it as well, because then that patient could be, or that child could be at risk for SMA, right? So these are things we can do, and they'll become more common, like 23andMe and these other types of genotyping sort of companies can give you more ideas about, what are you at risk for? Like, how do you metabolize caffeine? They can tell you all kinds of different things, right? Look at services, social, and spiritual factors here. So these are kind of interesting ones where, and a lot of this goes back to the societal sort of beliefs and practices of individual populations here. So, for instance, in terms of service specifically, they're talking about the Institute of Medicine and talking about how common medication errors are, just medical errors are in the hospital. And so, like I always say, the hospital is the worst place to get better because the longer you stay there, the more likely you are to develop what?
Nosocomial infections.
Nosocomial infections, you can get medication errors, you can get all kinds of errors that can happen to the patients. And so, again, a lot of deaths are attributable to those medical services, right? And so this is one of those cases where, again, we can look at the actual impact of that, maybe look for changes. And you guys ever heard of the Joint Commission? With the Joint Commission, they're the main accrediting body for all the hospitals in the U.S. Like, they make big changes based off of these factors here. They're looking to see, well, why are these medication errors occurring? They put in safe practices that all hospitals need to follow in order to make sure that these things don't happen. So, for instance, like when you do, before you go into surgery or do any kind of procedure, you always do a timeout. You know what a timeout is? What is it? Everyone stops everything they're doing. You say, okay, this is the procedure we're going to do. Here's the patient we have. Here's their MRN, their date of birth. We're going to do it on this leg. We're going to chop this leg off, not that leg, right? Whatever thing you're going to be doing. Here are the people in the room, right? You do all that stuff because that helps to make sure that you can identify any problems before you get started with the actual procedure. That is part of those safe practices because that was the place we saw errors were occurring there, right? Look at other factors here. So, for instance, here's a case where they're looking at health and disease in Mormons and Seventh-day Adventists. So, looking at actual spiritual practices to see how it would have influence on disease. Now, would you think that a person's spirituality would have an effect on things like metabolic diseases? Could be. Like, what do they eat, right? So, do they have certain dietary restrictions that may affect them developing certain diseases? They actually did find that. So, for instance, Mormons, they prohibit the use of alcohol and tobacco, right? So, do you think you have very high lung cancer rates? No, that's not to say that everyone follows those practices, but for the whole, you might imagine for the average, they would have lower tobacco use rates than you would say non-Mormons. And so in those cases, they can find those kind of links there. Or for instance, Seventh-day Adventists, they avoid alcohol, tobacco, and they also strongly encourage members to eat a vegetarian diet. So what do you think it does to, say, heart disease rates? Probably goes down if I had to guess, right? So again, these are things we can just look at. We can look into and see if there's any of these links here. And again, it may not be making any changes, but it's good to know, hey, your patient, you know, is a Seventh-day Adventist. What do you know about their disease risk, right? That can sometimes play a role. Anyway, again, looking at ecological issues here, we can look at, you know, we usually think about like human ecology, medical ecology, but you also have to think about like the geographics of the world and how those things are sort of changing there. So for instance, if Florida is, you know, no longer a peninsula, but is just underwater in the next 20, 30 years because of global warming, that could be an ecological factor, right? So that's something we have to consider. You never know, right? Polar caps are melting. But anyway, again, we have to think about them as kind of living in these communities. Know that it's a complex ecosystem that we're going to be dealing with, and it will change greatly from one country to another, right? If they're dealing in the U.S., Japan, Europe, anywhere you go. So, because we know people are growing at exponential rates, we had a population of about 7.4 billion people on Earth in 2016, and also how is life expectancy going for these individuals? Typically increasing, right? So populations are getting older as time goes on, and so we're starting to see more of these chronic diseases starting to pop up. We're also seeing greater, you know, strains on the world in terms of resources and things like that. And so again, we can look at these changes over time to see what are we doing and how is that having an impact on things. And again, not all the changes that we make here are always going to have a positive impact, you know, because again, we can find that our effects on the ecosystem can be quite deleterious, as we know. So. Just cover a couple more slides and we'll go into a break. But anyway, so looking at vaccination patterns of immunity, right? So kind of getting into a few details on this one. So if you understand herd immunity, it's helpful to understand some of the problems we can run into in terms of immunizations today. So as I mentioned, if there is no herd immunity against a disease and everyone happens to be susceptible, you're going to find that the number of cases tends to double every disease generation, right? Because one person can then spread it to 2 people, and they can spread it to their 2 friends, and they have 4 people, and then 8 people, right? So you can see that it multiplies pretty steadily there. Looking at, for instance, I'll show you a picture of this in a moment. If you have 50% herd immunity against diseases, you tend to find that the number of cases remains pretty small and pretty constant there. But once you tip over 50% herd immunity, this is where you start to see the disease numbers actually start to dwindle out, and eventually you should die out at some point. And so if you can imagine here a case where there are absence of herd immunity, and the pluses are going to be people that get the disease, and the minuses are going to be people that are protected. You're going to find, or the circles around the negatives are people who are protected, say with immunization. The negatives are just going to be people who are benefiting from the herd immunity. So if you imagine here with no herd immunity, one person gets it to 2, they give it to 2, they give it to 2. You can see the disease generation sort of progressing on there. Versus if they have the herd immunity, say 50% even has it, you're going to see here that this person's protected, so who do they spread it to? Well, nobody, because they never got the disease in the first place, and so the 4 people that they would have spread it to, they don't get it either, right? Versus here, you'd find, again, 50% herd immunity. Again, you see the numbers eventually dwindle out to where we only have, say, 4 people versus all these people in here having the actual disease. That's kind of the principle behind the herd immunity and why it's so important. So, again, we're going to see the degree of immunity can, or the ability to actually just eliminate that virus from a population can vary on several things. So, for instance, the type of virus, the time of year. So, like, when do people normally get the flu? Winter months, most likely, right? So that's where you're typically going to see that most commonly. The type of virus, again, can be a big factor here. So for instance, every flu season, are we dealing with the same strains of flu? No, they're constantly changing, right? Our flu virus is constantly changing, or flu vaccine, I should say, is constantly changing to protect against different strains every year. And again, just the density and social patterns of the population will have a big role here as well. Do you think disease more likely spread in really tight-knit communities where they're very close together, or more rural communities where they're more spread out? Right, the more huddled together they are, the more likely they are to spread disease. So for instance, if you're riding on a busy subway, there's a lot of people all in close contact versus if you're out in the middle of nowhere and you're riding your bike down to the CVS or something, right? That's exactly how my town was growing up. So again, we'd have very low disease transmission versus somewhere much more densely populated. But again, we know that it gets a little bit more complicated than that. It'd be nice just to get everyone immunized, but that may not always be possible depending on comorbidities and different issues there. But for instance, when you look like diphtheria, this is one that they initiated, and they did definitely find that giving the vaccine caused a decrease in rates of diphtheria over time. And again, when it was a more common disease, people who have been vaccinated against it were more frequently exposed to the causative agents. They're more frequently exposed to diphtheria. And what they would end up developing is more of a minor reinfection later on, right? And so one of the things we'll talk about vaccines is the vaccine memory, or how long you're going to stay immune against that particular disease, right? So now typically when you think about things like tetanus, what do we have to give every 10 years or so? Tetanus booster, right? Why do you do a booster? You re-challenge the immune system, and that helps to refresh the memory of it such that you, next time you're exposed to it, you have good protection against it, right? And so again, this produced basically a natural booster effect. So when it was more prevalent in the population, people who had the vaccination early, even if they started to lose some of that protection, they would get exposed to it again, just get a really mild reinfection, and thus they were kind of renewed for later on, right? So that was all great and good. However, as you found that diphtheria became less and less common, these people who were vaccinated early eventually lost that protection, and then on the off chance they were exposed to it, guess what happens? They get the disease, right? So for instance, in Russia, despite they had diphtheria vaccine given to many children, they actually found that adults who either had not been recently been in the military where they would have received the vaccine, or they're found to be susceptible, they started to develop this epidemic, right? And they said epidemic is just what? Increase over the normal, right? So increased incidence of disease over what the historical normal would have been. And so now you have this major epidemic of diphtheria that was starting to pop up in the 1990s. And then by 1992, around 72% of those cases happen to be in individuals who are older than 14 years. So again, even though if they got vaccinated as babies, what they found was that past that 14-year mark, your susceptibility tended to go up. And because the disease was not super common at the time, you ended up losing that protection, and thus now the epidemic was kind of primed to go. And again, not due to a lack of initial immunization, but it was basically the fact that the older people, they were losing that immunity levels, right? And so, for instance, if they want to check to see if you are still resistant against hepatitis B, what do they check you for? You ever had like titers checked before? You probably will if you go to work in a hospital or something like that. They'll check for Hep B titers. Again, that is checking to see, like, do you need that booster, or have you lost enough of the antibodies such that you may be at risk for developing it if you're in close contact with patients who happen to have it there, okay? And so again, before they actually had it under control, they had about 125,000 cases and 4,000 deaths associated with that. And so again, that would prompt us to change how we actually vaccinate those individuals and maybe give more doses, give more booster doses to prevent that from occurring. Okay, so let's do a 10-minute break. We'll come back and continue on with this lecture set. All right, let's look at some other epidemiologic interventions. Actually, is there any Any questions before I get started? I should be looking at you instead of looking at my computer when I ask that. Any questions? Oh, there's a few. All right, fantastic. Wouldn't the new use of Uber and Lyft cause more people to drink and/or overdose? That is also a question. Perhaps that is a unintended consequence. So you can have maybe safer drinking. You say, well, I don't have to drive, so I can go ahead and go 9 sheets to the wind, as they say. There's 3 sheets to the wind. You're on cloud 9. I don't know what the aphorism is,
I don't know
but
colloquialisms.
yeah, colloquialism. Anyway, yeah. So again, that's the thing they would look at, right? You could look to also see like, hey, maybe our hypothesis is also that maybe we're seeing a higher incidence of alcohol poisoning associated with the increased use of rideshare apps and things like that. It's a good question. I have no idea. Any general advice on how to study for this exam? Same way you study for all your exams. This will be another test, kind of like the first one, where it's going to be a lot of interpretation of a study, that kind of thing. There'll be some of the definitions. I mean, it's pretty similar to the first test, and you guys did very well on that one. So I wouldn't expect you to have any problems. And guess what? We'll have another review beforehand, so nothing too much worried nothing to be worried about at that point. Okay. And if your professors tell you not to worry about something like a quiz,
You should probably worry about it.
what? No.
Got us in trouble with
No. We always mean what we say. Say what we mean.
Rip home.
So again, in this test or this PowerPoint slide, these slides, this first one is just really an introduction, right? We'll get more into the specifics as we go on. It'll be more clear what the test material is going to be like. Okay. Let's see. How common is it to need a hepatitis B booster? I thought the original titer would provide lifelong immunity, and a majority of articles online say that it should. But after 20 years, I needed a booster. Is this common? Yeah, it's pretty common. I had to get one when I was first going into working at Nemours. They just did a quick titer. Said, yep, your levels look low. Let's go ahead and give you a booster. So I can't say how common it truly is, but that's common enough. They have to test for it, right? And that's why they would do that. So. But yeah, then you're pretty good. So I don't, we wouldn't need one for another good long period of time. So I don't know the actual rates. Does anyone know that by any chance? No. Most people had to get one. Did you get a whole series? Oh my goodness! I just got the one-time booster. Oh my goodness. For the school, yeah. So. Huh? So that's the thing too. So it depends on the organization you're going to and things like that. So school might want to be a little bit more tight about that because again, and again, I don't know if this is just like graduate versus undergraduate or anything like that. But again, when you have a lot of people coming together living in the dorms, especially an undergraduate, that's where you start to worry about things like infectious disease spreading there. I remember my sister when she first moved out of the house, and she's like 7 years older than I am, so she moved out. We were still in middle of high school, and she moved out and she went to college out of state, and she within the first week ended up developing mono and had to be like segregated out of the dorms into like her own room, and yeah, so again, moving into dorms can be a big infectious disease risk for sure. But anyway, so I don't know if that applied to graduate students, undergraduates, or who, but anyway, it is what it is. Now you're all protected against hepatitis B, so that's exciting, right?
Yeah.
All right. So anyway, let's look at some other issues here. So TB, we talked about that in pulmonology just recently. And again, this was one of the largest killers of adults back in the day, right? Back in the 19th century. However, one thing what we saw was the effects of sanitation actually had some big effects on infectious diseases as time went on, right? You think infection or sanitation would always be a good thing, right? Probably. However, there are some unintended consequences that you can see later on, especially when you're looking at things like mortality rates for individuals. So looking at this, we did see that they had the sanitary revolution in England in the middle of the century, and they found they had a huge effect on reducing the infant mortality rate, right? So infants were surviving more commonly, and so they found that what would that do to the population, you would expect? Huge explosion in the population, right? And again, it's one of the reasons for some of the population issues we have today, why there's 7.6 some odd billion people in the world. And so we find that with a reduction in infant mortality rate will help to kind of produce a big difference between the birth and the death rates of society, you're going to find that also causes that huge rapid increase in growth there, right? So we call this a demographic gap. That's where we're starting to see kind of the opposite effect sort of happening here now, right? We're starting to see like the boomer generation is starting to kind of age out a little bit. They're getting older, they're retiring, but they didn't have as many kids as their parents may have had. So now we're starting to see that the population is starting to dwindle back down a little bit. So you start to see this kind of ebbs and flows as time goes on. But again, here's an example where the control of infant mortality tend to have a lot of effects on the culture, and we use that in some cases, or it can be a way to control population control. And in fact, actually, I just saw an interesting piece just recently. Anyone watched Last Week Tonight? John Oliver. There's a piece about China, and they're talking about their one-child policy. So you can actually look at that and see some of the effects that one-child policy has had on the country. It is kind of interesting to see how that has the effects there. But anyway, when you end up seeing that the infant mortality rate is high, it's two now. He talks about that. It's great. But for a long time, it was just a one-child policy, right? And then now it's a two-child policy. But it's really, really interesting. I would certainly suggest checking it out just to see just some of the unintended consequences that sort of had on their economy, on their culture, on everything. It's really, really interesting. Anywho, so when the infant mortality rate's high, you tend to see that will affect how many births you're actually having. So for instance, if you have a high infant mortality rate, what's the number of children that people are going to try to have it? Or at least the number of pregnancies. It's probably going to go up, right? They're going to try to have as many kids as possible because they're trying to ensure that at least some of them are actually going to make it into adulthood. Has anyone ever seen Monty Python's The Meaning of Life? Yeah. Right, there's a big scene, and this basically there's this English couple, and they end up having all these children in the house. It was about Catholicism. Now every sperm is sacred. That was basically the song, and so they ended up having all these kids around. But that was kind of what they were looking at, because they wanted to make sure that some of those kids actually made it into adulthood. And so again, when you end up having low infant mortality rates, the population grow, and it's high infant mortality rates, the population tends to dwindle, right? And so what we end up seeing is that we also found disease patterns were affected pretty significantly by that sanitary revolution and as well. So again, you would see that one of the big causes, one of the big changes that happened here was this epidemic paralytic poliomyelitis that happened late in the 19th century there. I know it's hard to say, especially at the end of the day. It's very tough. Paralytic poliomyelitis. I know. I didn't even know you can get inflamed polio.
Just polio?
Yeah, just polio. Yeah. Very good. Thank you for your contributions. Yes. And you'll be on the recording too. It's fantastic.
It's a recording?
Yeah, always record.
Wow. Better name being on that.
Very true. Very collegial atmosphere amongst all the faculty here. So sometimes I'll use them to jump in the back and scare everyone awake. If it's like an 8 o'clock class and it's going really slow, we'll do that. So be forewarned. Anywho, but basically what they're finding is that when you're having this increased sanitation, you're finding more of these individuals are being infected with the disease. And the question was like, why was that actually occurring here, right? And so they also was delaying the time when most kids were actually exposed to it. So before they were actually exposed pretty early on to the disease, so they ended up developing an amount of immunity to it. As sanitation got better, you tended to find that they were less exposed to it, and so they were later in life when they ended up getting it, when it was much more potentially deadly for those individuals. And so most of the kids were exposed after they were no longer protected by maternal immunity. When I say maternal immunity, what does that mean? I feel like you drop the lamp and you blame your little sibling on it. Like that maternal immunity, you're going to be in trouble. Just kidding. No, what is that? Yeah, it's like natural immunity you get from. Yeah, so you get some transfer from, say, just blood transmission between the mom and the baby, but once they're born and they have breast milk being fed to them, they can get some antibodies there, and they can develop some protection. So if the mom was protected against polio because she might have been exposed to it at some point, these kids are also being protected to it as well. And again, how long does that protection usually last? Could be up to a year in some cases, right? We'll see that can actually affect what kind of vaccines we can give individuals later on. We talk about vaccines specifically, how like you don't want to give live vaccines to kids that are less than a year old because the maternal immunity actually helps to render them ineffective. But anyway, So what you're finding is that these kids were later on getting it when they didn't really have the maternal protection. So before they would have been have some degree of protection against that, but now they're starting to lose it. And so what they also found was that people of the upper higher classes, socioeconomic classes, where the sanitation was presumably even better, they were even hit harder because they were even less exposed to it, especially very early on in life. And so that was all up until the polio vaccine became a thing that was around and was available for those individuals. So again, it was one of those things where the cases of this poliomyelitis was developing as an effect of the sanitation. So infants were surviving for longer, mortality rates were going down, but now we have more cases of polio. Again, it's an unintended side effect of some of these positive changes here. Excuse me. But then looking at some of the initial hypotheses about the disease, they'll look for these causations, right? So they'll kind of develop, what do we think is actually causing this? And they'll try to go back and look at these investigations here. And again, we're finding that as we look back in the past, we're able to get better ideas about the agents and the modes of transmission, things like that. And again, knowing this is going to also help us to determine how we can best prevent it in these cases here, right? So we're looking to see how we can do that primary prevention before the disease even starts in the first place. Here's some agents here we can actually find by doing these investigations and testing hypotheses. We're able to know, one, how the agent or what the agent is and what the route of spread is, and then methods of prevention. So for instance, if you can get Lyme disease from ticks, avoid ticks. Seems pretty straightforward, but if you didn't know that ticks cause Lyme disease, you wouldn't know to avoid them, right? Right. Or for instance, toxic shock syndrome, right? So avoid using long-lasting tampons. Before they would use tampons that would be kept in place for long periods of time. Once they finally realized, oh, wait a second, this is leading to the staphylococcal toxin being released, causing toxic shock syndrome. Toxic shock syndrome is another hard thing to say 3 times fast. However, you're finding that they can now learn ways to avoid it potentially, right? So these are just some examples of things. Again, don't memorize this entire list here. It's really just to illustrate the points that we can, by testing these hypotheses, looking at the epidemiology, we can determine ways we can avoid some of these issues here. So again, some other changes, some other things that we've made contributions to with epidemiology. Identifying cases of a new disease that are fatal or severe, and that will help us to look and get further information, because what you end up finding is whenever you have a new disease kind of rearing its ugly head, you only find the severe cases first, right? Because they tend to be the most severe, they tend to be the most kind of attention getting. But by being able to identify that, you can kind of look to see, well, there's actually more people that have it than what you think, but they may be asymptomatic or they may be less clinically severe. And so this is kind of what they call it, the iceberg phenomenon, okay? Again, the more you know about the disease, the more you're going to find these individuals who may be asymptomatic or maybe in kind of the pre-disease state that you can maybe help prevent or treat earlier on. Okay, and so again, asymptomatic infection can be uncovered either by finding things like elevated antibody titers potentially. You can look for the organism specifically, or you can actually find, by culturing individuals and seeing, do you actually grow out the bug itself, right? And so, as I mentioned, this iceberg phenomenon, we'll kind of show you a picture of that in a moment, but that severity of disease process is referred to that spectrum of disease, right? So again, when you find a patient that dies from a pseudomonal infection or something like that, again, those are very severe cases. It's not certainly going to be the majority of them. So for instance here, you may find people who are developing clinical illness and potentially death here as being these kind of visible cases, but certainly there's going to be people who are asymptomatic or maybe not late enough to where they actually become symptomatic here. And so by being able to investigate these patients here and looking to see who are the asymptomatic ones, you're better able to screen for them and be better able to hopefully prevent them from getting to this state if possible, right? So, and this is where we can do things like randomized trials of preventative measures, right? We can do things like randomize people to either get one form of preventative help versus another. We can try doing things like vaccine versus no vaccine. You can do different types of randomized trials, and oftentimes these are called field trials, and they will give us an idea of how effective different interventions might be in preventing disease. And then if those turn out to be effective, then they can do things like look at more large-scale sort of implementations thereof, right? So maybe in the whole population of the state of Florida, it could be across the U.S., depends on the situation there. But it's always important whenever you make a new intervention, what do you do afterwards? You got to make sure it's working, right? So this is where surveillance is also going to be a really important point of this, by actually doing the ongoing surveillance, looking to see, and for instance, like if you introduce a new vaccine, looking to see what are the side effects, what are the unintended problems of introducing this. So as an example, have I mentioned like when the swine flu was becoming like a big deal? This is probably like 2012-ish, I would probably say. I was rotating in the PICU, and I remember like swine flu was the first thing that hit. And the first kid I ever saw going on ECMO, which is extracorporeal membrane oxygenation, basically a machine that ran, basically acting as lungs and heart for the patient, was due to the introduction of swine flu. And it was this kind of new thing they introduced, and that's why nowadays, when you think about the flu vaccine, anyone know how many strains it protects against? 4 strains. I think I mentioned this the other day, but 4 strains. It used to only protect against 3 strains. It used to be 2 strains of flu A and 1 of flu B. Now we have 2 of flu B, and that includes the swine flu. The reason for that is because it was becoming more prevalent. We knew it was becoming a big issue, and so we had to get a new vaccine to cover for that. Well, once you introduce that new vaccine, now you have to do that new monitoring to see, like, well, is it causing any problems? Are there neurologic issues developing here? Are more people developing anaphylaxis? All kinds of things you're looking at to see, okay, is it effective and is it safe for these individuals, right? So just as an example, here's some other cases where, say back in the 50s, there was a large-scale field trial for this new inactive polio virus. That's what the IPV stands for. The Salk was the company that actually made it. They were confirming, yes, the value and the safety of the vaccine. Everything looked like it was pretty good. And then in 55, they had this polio surveillance program with the CDC. What does CDC stand for? Right. Anyone know where they're based out of? Atlanta. Yeah, Atlanta, Georgia, right? Like first season of The Walking Dead.
I knew you were going to say that.
Why did you know I was going to say that?
Because it was a big part of the first season of The Walking Dead.
That was like the whole first season of The Walking Dead, right? But yeah, the CDC was a big, you should go watch first season of Walking Dead. It's pretty good. But yeah, so Atlanta was a big place for that, for the CDC, and actually this is where they do a lot of this monitoring, especially like across the nation. They will have a lot of different monitoring programs that are going on. But anyway, so they discovered an outbreak of this vaccine-associated poliomyelitis, and they linked it to this Cutter laboratory. So basically it was another lab that was making this vaccine here. And so what they found was that they had a slight procedure change, where it was actually producing the vaccine was having this clumping of the virus to actually occur there. This live virus is happening. And so what was happening is that the vaccine surveillance program, they're able to look for these new cases, and they look to see, like, well, were these patients vaccinated? So yes, they were vaccinated. And then they could do further investigations. Well, which brand was it? What manufacturing did they actually get? And so anytime you get a vaccine administered, guess what they do? They monitor all that stuff. They look to see what was the lot number, what was the expiration date, what was the manufacturer of that vaccine, so that way they can track for these things and look for things like bad batches. And we know when I say a lot number, what that means? Check like any medicine like you have in like your cabinet when you go home, and you'll see there's an expiration date and there's always a lot number associated with it. That's basically the batch of the medication that was produced at the same time. And so frequently if there's ever like a recall or there's some issue with the drugs, they go back to look for the individual lot numbers, and so that's what that's referring to. So if you hear like a bad lot of drug, that's what they mean essentially. But again, it was only because of that surveillance program they were able to identify those individuals developing poliomyelitis and able to link it back to that individual manufacturer of the drug there. Right? So that's why surveillance is super, super important. However, is surveillance cheap and easy to do? Yeah, typically not, but it depends on the type of you're doing here. If it's active, ongoing surveillance, it can be pretty tough, as we'll see. They could also detect things like outbreaks of measles that occurred in 71, 77, etc. They're able to show that a lot of the unexpected disease occurrences were happening in these college students and people who got the measles vaccine before 12 months of age and without a later booster dose. So we were able to link it back to say, well, okay, well, what's kind of the common link between these patients? Why are they developing measles at these times here? And they could see what are the common occurrences, what are the type of patients they're looking at, what are the common threads. So it's kind of like you ever see like a movie, the scene where they're like red strings going all across the room and they're linking all these different things together. I kind of think about epidemiologists like that, and they're kind of like the crazy people trying to make all these connections. But you can find things like this where patients, they found this common links between them, and then they can go back to see, well, what should we change about this to make the difference? And so they found that the timing of the vaccine really did matter, because it was given during that first year of life. The maternal antibodies were high enough such that it inactivated the vaccine, or you did not get a very good response to it. They also found that maybe just a single dose wasn't going to be good enough, because without the booster, they end up losing that durability of that response, right? They lost that memory, so to speak, of the virus, unless they were not protected later on. And so that's why we changed the recommendations, and we initially give it, say, at 15 months of age instead of earlier during that first year of life. And then we give a booster dose primary, or before they go into primary school, and then also potentially before they graduate from high school, right? So by doing that, we make sure that they have insured protection, especially when they go to places like college or other environments where they're around a bunch of new people. So But of course, we can't monitor for everything the same, right? We can't treat every single disease as such as it's the most important thing in the world. So setting disease control priorities is a really important thing to consider as well. And so usually you're going to find that things that get a lot of attention, especially a lot of news coverage, tend to get a lot of high priority, at least up front. And then as things start to simmer down a bit, then so does the priority of it. And so where do you think this is set at? Who sets like the priority for these disease monitorings and things? Could be the CDC. They could help us out with that, surely, because they're doing a lot of surveillance. But certainly things like the federal government can have some role in looking at this stuff. But state governments as well. So for instance, the Department of Health, do you think that, again, the Department of Health in Arkansas is going to care about marine envenomations? Probably not, because again, they don't really have a whole lot of marine envenomations there, versus here we might actually care about that. Or for instance, you think about the dinoflagellates over in the Gulf Coast, right? The red tide, anyone remember that? I think it was a recent thing in the past year or two. That's a huge public health risk, right? And that was the thing where, again, if you were in a different state, they probably don't care about that. It's not a big concern. But here, it became a big concern for us. We started to investigate that and track it more heavily. So again, just as an example here, and again, legislatures that fund these diseases, whether it's state or federal level, have a big role to play in this. So for instance, in the 1950s, they had a big drop in the rates of syphilis in the US, right? However, because that became less of a priority, people cared less about it. You end up seeing kind of a rebound effect that happened there later on. And a lot of it can have to do with health funding in terms of like prevention programs, actual treatment programs, and things like that. And again, you can't really kind of control for everything. So this is why we see natural ebbs and flows in some of these diseases. So based on some of the studies in the 80s, they were actually finding that the potential threat for AIDS was huge, right? So in the early 80s, we didn't even know about the disease for some period of time. And we were seeing that a lot of those patients were dying out because we didn't really have any effective treatment for it. We didn't really know what the disease was. Like it was a really tough time. You guys watch the band played on? Yeah, so you gotta have some background on kind of what that time was like for a lot of those individuals there. There's another movie, I think it was a Netflix documentary. I'm not sure if it's up still or not, but I believe it's like How to Start a Revolution or something like that. But it was basically about these individuals, these activists who were trying to get more medications approved and pushed through the FDA to actually treat HIV. They knew these medications and chemicals were working, but a lot of the governmental red tape was preventing them from kind of going through. It's another interesting documentary. But anyway, once we realized that there was an AIDS epidemic, right? Because would that have been an epidemic back in that time frame? Right? Because the historical rates was what? 0. This is a brand new disease, right? So this is a case here where because it was in the forefront of the news and people were thinking about it and legislators were thinking about it, this is where it got a lot of resources, right? So we got more researchers looking at it, more drug development was happening with this, a lot of efforts were focused on it, right? And so you saw this increased number of cases as well, because again, a lot of patients might have had the disease but not actually even known about it. But if you hear these news stories that come on, that say, oh, there's this new disease that's out there, it's called HIV, it's called AIDS, people are going to start to think, well, shoot, maybe I have it, right? And so more people will then present who maybe not actually have it, but you may be more likely to catch those people that actually do have it. And so again, this is good for helping to actually find true numbers of these things, not just finding those people that are at the tip of the iceberg, so to speak, right? So, but in the 21st century, you see things like smoking has declined. Certainly not all smoking, as we're seeing with some of these e-cigarettes and things like that. But certainly in terms of HIV and AIDS, we've developed a bit of a level of control over that, right? So for the majority of people with HIV nowadays, do they die from that disease necessarily? Not really, right? They're living for a lot longer. They're actually dying of other complications, right? They're dying of heart disease and they're dying of stroke and diabetes and things like that. And so because of that, do you think it's as high a priority as it was back in the 80s? It's kind of dipped down to some degree, right? There's still a lot of funding associated with it, but it's not going to be the same fervor as what you'd expect if you saw it in the news every single night, right? But certainly we're starting to see more things like increased caloric intake, sedentary lifestyle, etc. And so now, now we're maybe looking more closely at things like the obesity epidemic, especially in kids, childhood obesity. So you start to see more programs associated with that. Like for instance, like Michelle Obama, what was her big deal? Getting kids active, right, and things like that. So that was something where at the federal level they were setting a certain priority for this particular disease state that they were actually really interested in. So again, it goes to show you that these priorities will change depending on who's in power, the state and the federal level potentially. So what are some things we can do to kind of improve our diagnosis, treatment, etc.? Again, you're going to find that very frequently a lot of our epidemiologic methods help us to improve the clinical medicine that you provide to your individual patients there, right? So that way you can have a better idea of how you screen for certain diseases, how you're going to actually treat those diseases, and what the prognosis is going to be, right? So by looking at these trends in the populations, you can try to generalize that back down to your individual patient. And so, for instance, some of these tools can really help us in terms of diagnosing the disease. So like I mentioned with Ebola, we were asking patients as they came into the ER, even if they had no symptoms that were necessarily associated with Ebola, have you had any recent travel to, say, to the Congo? That was something that could have tipped us over to say, okay, well, maybe we need to investigate this further. So even simple questions can be enough to help with these kind of pre-screenings and helping to get better diagnosis for your patients. Certainly, we're going to see, for instance, like one trial, there's a randomized controlled trial here, so we know what those are for sure. They're testing a hypothesis that methylprednisolone reduced spinal cord damage and improved residual motor function for acute spinal cord injury, right? So again, they're looking at the epidemiology of it, looking to see these spinal cord injury patients, what was the best way to manage them, and they found that you should probably give steroids to these patients. Helps with swelling, helps to preserve function, etc. So again, just one example. And so also helping with the prognosis, we can know that depending on different diseases, how patients are going to do, right, based on different interventions we're going to have here. So for instance, using a case control method, they compare two different coronary prognostic indices, and they can look for the weaknesses of them, look to see, okay, well, how do these patients do depending on different factors here, and try to determine what's the best way to know how your patient individually is going to do in the future there. Right? Because then oftentimes patients want to know, like, well, what are the chances of this happening? Or what are the chances of this working? Right? And so this kind of data can help you answer those questions there. And again, we also can help you with things like showing you like risk estimation, right? So you've heard of the Framingham Heart Study, right? What is that study? Framingham, is it Vermont or Connecticut? Massachusetts? Okay, thank you, Massachusetts. And so basically they're tracking these people, and this is like just a crazy study because they've been tracking these patients for like decades and decades. They're looking at things like smoking, obesity, heart disease, diabetes, looking at everything essentially. But again, they give us a lot of information about saying things like, okay, well, what are the chances if you have these different factors of you going on to develop a heart attack, right? Other than that, things like, methods to determine what your risk for breast cancer is based on certain mutations and things like that. These are things that epidemiology can help with. And so other things we can do to help improve the health services research, we're going to find that a lot of the statistical methods we looked at are going to be useful here as well, and the journal clubs we're going to use are also going to be kind of looking more on the epidemiology side of things here. But basically they can help us to determine what sort of community health needs we should be focusing on, what are some things that we need to kind of divert more attention to. So for example, looking at state funding for things like opioid use education, right? So for instance, like myself and Professor Lack are working with a group called the Area Health Education Councils, AHEC, and that's a Florida organization. They have different groups all throughout the state, and basically they have funding from DCF, which anyone know what DCF is? Department of Children and Families. They had a grant money that they provide to AHEC to say, hey, we want to educate providers about opioid use or misuse and abuse and ways we can actually help to treat these patients. And so they actually were able to give funds to them, and they found experts that can come talk about it. I don't want to say I'm an expert necessarily, but I know more than some providers. And so I was able to come in and actually give talks to these people because it was a priority to DCF. Because how do you think the opioid abuse affects DCF? Well, if you have a bunch of parents that are diverting money away from, say, buying groceries for their kids instead of buying opioids, that directly affects them, right? So again, anything you could do to curtail opioid use may affect their children quite significantly, right? So again, the priorities get set by various organizations here. But we can try to estimate, okay, well, what is the impact if we implement a program where we're educating providers about opioid use? How does that affect things like overdose rates? How does that affect the number of patients who are reducing the amount of opioids they're receiving? How does that, you can look at anything really. And so this is what these kind of studies help us with. And so again, looking at the analysis of patterns for disease frequency, looking for the use of services can be really good estimations of kind of the needs in the future. I'll tell you, there's one case where typically like poison centers, we rely entirely on state funding in order to operate. In every state, poison center is based off the individual state. There was a case where Alabama, they actually had their state funding pulled, and they actually had to shut down the Alabama Poison Center for like a year. And so they wanted to see what the impact of that was. And so if you had all these people who normally call in the poison center to say accidentally swallowed 2 Tylenol instead of 1 Tylenol, now you as a fledgling healthcare provider, would you say it's a big deal? But if you had no one to call and you had no medical knowledge, would you think it's a big deal? Potentially. So what do? Go to the ER. So they had all these extra people go to the ER, and they actually found these numbers were surging, and the cost associated with the ER, they said, well, shoot, it's a lot cheaper just to run the poison center. So guess what happened? Poison center opened back up, and boom, now they see the numbers go back down to the stable baseline, right? That's not to say the poison centers are awesome, but we are. But it's just to say that you can see the cause and effect sort of analysis here, right? So we're saying, well, shoot, just running a relatively cheap call center where you have a couple of nurses, a few docs who are on call can actually manage these patients without them ever having to go to the ER. Saves you a ton of money, right? It just makes sense from that standpoint, right? Cents and dollars. It's at the end of the day. But again, this is the point of these programs here, is to look for the actual impact, and a lot of it can come down to monetary impact. So that's it for this section. You guys have any questions so far? Yes. Yeah, it's a very good question. So how do the epidemiologists actually get access to the information? So there's a plethora of different things. We'll talk about surveillance systems a little bit later, kind of in its own section, but just briefly, it depends on who they're tapped into, depends on who they work with. So for instance, the National Poisoning, the National Association of Poison Control Centers, we actually send all of our data up to one central database. And I think like DC or somewhere like that, so I think it's all stored. So basically you have all 50 states have information all kind of going in at real time, going into one place. So we can actually see, and depending on the epidemiologists that are working with them, or people who have licensed the ability to work with that information, they can look for trends and things like, are fentanyl overdoses all of a sudden spiking up in Florida, and maybe that portends for the rest of the surrounding states, and maybe running into that, right? Or for instance, you guys remember when the Fukushima power plant basically exploded after that tsunami several years ago? You guys remember that? It was a big deal. Big Houston, vaguely. Okay, I was in middle school at the time. So that happened when I was actually in fellowship, and that was something we actually had to monitor for, because they said, is there any bit of radiation that might actually travel across the ocean and affect our patients? But also, what do you think patients are going to do, or people at home? Well, shoot, man, I might be irradiated by this stuff. I should probably call somebody about this. And so we're able to look for things like trends in patients who either maybe having symptoms that maybe or maybe not related to something like radiation poisoning, but we also provide education for them. And again, that was something we set up in the course of like 2 days or something like that immediately after that occurred there. Also, a little funny story, my brother, he was trying to go visit a friend that lived in South Korea for just a visit, and so he was flying over, and he was supposed to have a layover in Japan. Guess what day he was laying over in Japan? The same day they had the giant earthquake, and so they had to actually divert him over to like a U.S. Air Force base, and he was like stuck on the plane for I think like 12 extra hours or something like that. He eventually made it to South Korea and saw his friend, but it was a harrowing experience to say the least. No DVTs were suffered by him.
That's what I wanted to know.
Yes, exactly. Let me check. I got lots of questions. Okay, let me see here. Don't leave just yet. Do you charge people when they call the poison center? No, we do not. We're actually a free service. You already pay for it when you pay your taxes, right? Because state taxes actually run for that. However, what if your animal gets poisoned? Most of the pet poison centers actually do charge you, so that's actually they can be pricey. So a lot of people will call us and say, Bingo got into some rat poison, and it would be like, I can help you like a little bit, but like people is really my expertise, not dogs, and so I'll have to refer them over to those those poison centers usually, and they're expensive. They charge per. So, but yes, let me see. Is the effect of sanitation also? Is the effect of sanitation also a reason for increasing allergy? I don't know. We should look up the research to see if that's a link. Maybe, right? Maybe if you're exposed to fewer allergens, maybe you're exposed to or fewer irritants, maybe you develop allergies to them later on. I think there is some association with like early introduction of peanuts into the diet, perhaps decreases incidence of peanut allergy later in life. So maybe there is some link there, but you can do the research. I don't know. Let's see. We give antibiotics for patients who have rhino rocket because it's considered foreign object in the body. What about tampon? So we gotta translate that a little bit. So what's a rhino rocket? Anyone know? Yeah, it goes to the nose, right? So it's like nasal packing for nosebleeds and things like that. That's interesting. You automatically gave antibiotics. I don't know enough about it to say if prophylactic antibiotics is necessarily required for that. I guess it depends on the duration, how long it's in, so to speak. But that is certainly still a risk as well. Just like with a tampon, you can see staphylococcal toxic shock syndrome. Same thing can happen with that rhino rocket. But I don't know that we would normally recommend antibiotics for anyone using tampons. Typically do not do that, right? Usually just normal changing of it is going to be enough to prevent that, any issues from occurring. Okay, any other questions? If not, I will see you guys next time. Enjoy the extra time.